I now announce the conclusion of inaugural ceremony. We will now continue with our next lecture. Dr. VAISHALI DESHMUKH next with us to discuss current guidelines for DM treatment, case-based approach. As medical practitioners, all of us come across patients with deranged blood sugars. Dr. VAISHALI DESHMUKH will enlighten us on current guidelines for DM treatment. Madam is consultant and head of endocrinology at Dinanath Mangeshkar Hospital and Deshmukh Clinic, Pune on professional front. While she is a gold medalist and recipient of many awards, she is also a founder and secretary of an NGO, SPEAR, and organizer of various academic events. To chair this session, I invite Akula's senior physician, Dr. Deepak More and Dr. Kishore Deshpande. Over to you, madam.
Good morning, everybody. We have been listening to the latest advancement and development in the diagnosis of diabetes, different clusters of diabetes and subtypes of diabetes, and knowing their phenotypes and different investigations and following these patients in different ways. In some patients, diabetes can be reversed. In some patients, they may be controlled on metformin, and ultimately they need to be on insulin and whatnot. These three wonderful, very informative lectures we did have in the morning, these previous lectures. But ultimately, we need to come to the treatment of diabetes. And for that, we have Dr. VAISHALI DESHMUKH, who will be telling us the current guidelines of diabetes treatment, and I am sure her lecture would cover most of the types and subtypes of diabetes, which will help us know the current line of treatment in diabetes. Madam, please.
Thank you, sir, and thank you all for inviting me here today, especially Anita, a close friend, our better half, Dr. Govind, the IMA Akola, the IMA, the IPI Akola, Maha Endocrine Society, and I will also pay my regards to Madam Arora. I think she mentioned a very important line before she left, that knowledge should be put into practice. And that's exactly the problem what happens with diabetes. Putting guidelines into practice is a very difficult task. Every year I see the ADA 2022, 23, maybe 24, but I don't know how many of us really can understand what those changes can be put into our day-to-day clinical practice. So what I've done today is I've tried to simplify it into whatever I have understood and whatever I have seen in my practice, and probably whatever we have heard since morning, we can try and implement in our own settings in our clinics and clinics at all the parts of the country, including the peripheral centers. So I start with a case. This is a young, early onset diabetes patient who is normal weight, has started with microvascular complications, and she is actually a, I don't see the slide, okay. She's a 41-year-old bank officer, diabetic since 9 years. She has a sedentary lifestyle, normal weight. She has started with neuropathy and is having microalbuminuria or non-proliferative diabetic retinopathy. She's struggling to manage her diabetes. She has symptoms of burning feet which disturbs her sleep. You see the glycemic control is not good. HbA1c around 10, fasting of 179, PP of 267, weight 69, BMI 24, USCR showing microalbuminuria. She has not started with any macrovascular involvement as of now. She is on 3 drugs. Metformin, highest dose, glimepiride 4 mg, 5-liters 15. So this is a common scenario that we come across in practice. Now, key issues here which need to be addressed mainly concern in terms of the glycemic control. We know that here the HbA1c of 10 is what is clicking me, and it is telling me that if I don't control this, the microvascular complication is going to increase day by day. She's going to land up with other complications. So first and foremost is what is the inertia of aggressively managing the diabetes. So that should be avoided. So what we have commonly seen, what Anita addressed in the morning, that you should start on early insulin, think of intensification of that insulin. I think that's a very important point, because in such a patient, if you are not going to be very aggressive and not going to enhance the therapy as early as possible, that's going to cause more harm than benefit. And here, early insulin, is it an option and why is it an option? What do guidelines say on that? And then weight maintenance, we heard Dr. Joshi saying that it is adiposity-based disease. So we don't want adiposity to increase further in this bargain of controlling sugar. Then you have these microvascular complications which you need management individually. You need to control. See, patient is not worried with the levels. She's worried with her burning feet. I need to relieve her. She's not going to come to me if I don't relieve her burning feet, even if you control her HbA1c to 6. So that is an important point. And I know this patient is going to worsen in her renal parameters. So nephroprotection becomes my duty for this patient. And nephroprotection, protection of her eyes, prevention of worsening of her vision is what is my job. Now this is a complex slide, but I will just try to simplify it. This is what the table of medications lowering glucose mentions. Now this patient is already taking a glitazone, she's already taking a sulfonylurea, she's already on metformin high dose. So you have very few options left for her. You have SGLT2 inhibitors, you have GLP-1 RAs, and you have insulin left for her. Now if I sit and wait for her HbA1c to fall with SGLT2 and GLP-1 RA, I'm sure that we know that these are drugs which reduce HbA1c by not more than 1.8 to 2%. So if I can get down that HbA1c from 10 to 8, even then it doesn't solve my job. So I need to be aggressive there. What I need to do is I need to think of the most potent drug in such a situation. So I think of insulin as the first option. So insulin, if you are worried, start with basal insulin. That's the simplest thing. Why? Because patient has unlikely chances of hypoglycemia when you start a basal insulin. Small dose. Begin with a 10-unit dose, one-time dose, bedtime dose. Most of the times, patient is no pricks. So the second thing you do is you just show the pen at that visit. At least initiate the talk. That is an important talk because you show the pen and the patient says, "Arey, itna sa needle hai, pata hi nahi tha." So this is the way the patient starts getting a perception that insulin is going to be required, and probably not at this, but at the second or the third visit, the patient is easily accepting this option. But insulin talk needs to begin here. And insulin, if the patient is willing, this patient is highly motivated, she's a bank officer, so definitely she will be willing. So starting on 10 units, telling her CGMS or titration techniques with monitoring is the easiest option at this visit. Here you don't need to talk about complications, you don't need to talk about diet, exercise. What you need to talk is, yes, I need to start insulin for you because your sugar needs to get under control as early as possible. And if the patient is not willing for insulin, you have an option of SGLT2 and GLP-1 RA as a additive therapy. Now we have oral GLP-1 RA also, and we have SGLT2 also in our basket. So you can add these drugs till the time the patient is mentally prepared to start with insulin. Additional benefit what offers with SGLT2 is that this patient will get nephroprotection with the SGLT2 data that is available. So any gliflozins currently are known to have a nephroprotective, cardioprotective benefit. So you are not doing harm by adding this to these patients, and you can give a time limit of 2 to 4 weeks for further control and then think of insulinization. But the inertia time on an average in literature has been around 7 years. Now 7 years of uncontrolled glycemia, you can imagine, can do so much of harm to the patient. So it's important to think of timely initiation, timely starting. The initiation is the major hurdle. Once it is started, patient is willing to take whatever you are going to say in the next few sittings. So what is the target is the second question I put in my mind. So this patient I have got into my clinic and I need to decide a target. Now if this same patient was 70-year-old, my target would be somewhere around 8 HbA1c. I don't want her to get hypoglycemic, she's old, she's not having anybody to take care of. But I showed you that she's a 41-year-old woman. So you can see that a 41-year-old woman, she has a life expectancy which is long. She has important comorbidities which have started. So I think that this patient should have at least a stringent control. So the stringent control may be somewhere around 6.5 to 7. So if I am worried about hypoglycemia, maybe I would go around 7%. But if I have decided, usually I do that at my papers corner, I write the HbA1c target for each patient in my clinic so that I know that this patient I have put as a target of 7. So I am going to treat her to that target when the subsequent visit. This target may differ for a young chap, or it may differ for a 20-year-old male or an executive person who it may go to 6.5 also. So individualize your targets based on what the guidelines mention. Guidelines are there to guide you. They are not there to tell you that you have to keep it at 7.5 or 7. You are going to be guided by the disease duration, life expectancy, comorbidities, and complication rate, and patient preferences. Again, preferences for needles, preferences for tablets, preferences for once a day, twice a day. This is all what needs to be considered when the patient is coming into practice. Now this is the current guideline chart you can see. Now if I think of glycemia control as the main aim in this patient, then my idea goes diverted from this chart. I don't see this chart at all. I don't see the cardiovascular atherosclerotic risk for this patient as of now. I see the glycemia as the first prime thing. And if you see in glycemia, GLP-1 RAs followed by SGLT2 followed by the insulin becomes the choice of therapy. Now once this glycemia area is controlled, then I go to this chart and then I see what is the atherosclerotic risk for this patient. So we know that microalbuminuria itself is a risk factor for cardiovascular disease. Then I think of using a GLP-1 RA and a SGLT2 for this patient so that I can give the benefit of cardiovascular protection, renal protection as well as glycemic control. So here I would not go the other way. I would not go on SGLT2 and GLP-1 first and then start insulin, but I would go the other way around based on the guidelines that are offered. Now, fortunately this patient has no concerns of weight, but when it comes to weight as a factor, we need to think of this third block also into picture. So, early GLP and insulin initiation, what does guidelines say about this? So guidelines say that as soon as the patient is getting uncontrolled, you need to think of starting a basal insulin and or a GLP-1 RA, and if it is not controlling with that, I think the print is small, so I'll go to this. So if you start with basal, the patient is not getting control, you can go to a premix. If the patient is on premix and not getting control, you go to 2 premixes. If the patient is on basal only, you think of adding a prandial insulin. And if the patient is on 2 premixes and 3 premixes, you think of multiple dose insulinization. So the need is for intensification. So starting, initiating is the first need and intensifying that is the second need. So insulin started, we have seen many times that insulin has been started, 20 units, 30 units have been started, patient is taking the same dose for years together without even changing himself or by the doctor. So that needs to be avoided to titrate to the goals of 100 to 130 fasting and 140 to 180 postprandials in the patient. So likewise this patient, the patient was then shifted to from metformin, sulfonylurea, degludec was added and DAPA was added, dapagliflozin. So we see that with the addition of this, within a span of 6 months, the patient's glycemia was much better with basal insulinization. So starting insulin, getting this patient in control is going to help in preventing progression. So this is the first case. Coming to the second case, this is a menopausal type 2 diabetes patient who is obese and has macrovascular complications. So 51-year-old woman with uncontrolled glucose, blood pressure also uncontrolled, BMI uncontrolled, 9 years duration, high risk of cardiovascular disease. She is already taking triple drug with DPP-4, metformin, sulfonylurea, started on insulin, is on telmisartan, aspirin and calcium. Now here the insulin, there is an option of insulin intensification or there is an option of adding something which will also protect her heart and the kidney. So this is what we need to offer. We know that when we are trying to treat diabetes, our aim is to reduce the diabetes complications through glycemic management, blood pressure management, lipid management, and also cardiovascular and renal protection. Of course, lifestyle modification forms the base of this. So again, the issues to be addressed here is weight control as a prime issue, then cardiovascular risk factor control, and then so much of polypharmacy. People don't want so many drugs. They want something which is combined into simple pills, single pills. So obesity itself is known to be a risk factor associated with high cardiovascular risk, especially in patients with diabetes, and you can see that risk of stroke, coronary artery disease as well as all-cause mortality is very high with obesity and diabetes put together. So it's like fuel to fire. So obesity definitely needs simultaneous treatment when we are talking about diabetes treatment. So what options do we have? We have GLP-1 RA, SGLT2 and metformin. Of course, DPP-4 and alpha-glucosidase are weight neutral, so these also can be an option for the patients. But why I have highlighted this in red is that this should go into your mind, that these are the only 3 options for this patient and the first outset. It's not insulin as the first therapy. So I don't want this patient to be on insulin because I know that she's going to get more obese. You can see her HbA1c can be controlled with GLP-1 RA and SGLT2. So though I mentioned in the first case that early insulinization is a need, for this patient probably insulinization is the last need. So you need to individualize when you're talking about this, and how do I choose the anti-diabetic then? So I think of these points. So in my mind I think of glycemic control, effect on weight, cardiovascular risk reduction, pleiotropic benefit and risk of hypoglycemia. And if you see that these 2 drugs, the GLP-1 RA and SGLT2, score the best when we are talking in terms of these parameters. So I don't want this patient to get hypoglycemic, I don't want her weight to increase, and that is why the choice goes upon decreasing. So I would not prefer a DPP-4 and insulin for this patient, I would prefer the first 2 options. So what is the current guideline again say for obese patients? Now obese patients, it mentions that GLP-1 RA forms the first base therapy for controlling glycemia. Of course, you have to control the glycemic arm first. So glycemic arm plus weight control, both is going to be one of the issues. And you can see that as far as patients' blood pressure is going, the blood pressure has a guideline mentioned that if the blood pressure is more than 140 by 90, that is the time you need to definitely start 1 agent at least. Now this patient is already taking 1 agent. She is still uncontrolled. So you need to think of starting 2 agents for her. What are the 2 agents? It is ACE, ARB is the first agent, and second is a CCB or a diuretic. So I decided to add a diuretic to this patient because I don't want her to put on more edema again with CCB. So that is the way I think of converting the guideline into my practice. Now if the BP is still controlled in this patient, what does the guideline say? The guideline says that you think of these 3 drugs first. If these 3 drugs are not controlling, you think of mineralocorticoid receptor antagonist as the 4th line agent. So this is how guidelines guide you to how to treat hypertension in patients with diabetes. What about statins then? So statins, you know that when the patient has not had established cardiovascular disease, the choice always remains in the terms of moderate intensity statins. So this is the arm which is required for any general diabetic patient. You can use any of these statins on the right hand side. But when the patient has an established heart disease or established kidney disease, then it goes which, this is a very important thing, that atorvastatin 40 to 80. I've seen so many bypass patients, I've seen so many PTCA patients who are on 10 milligram atorvastatin, who are on 20 milligram atorvastatin. There is a need to continue maintain high dose statin in these patients lifelong. And this is what patients don't understand, doctors don't understand. So it's important that these patients should be on very high dose statin to prevent further events occurring in them. Then you have an option of using anti-obesity agents in diabetes. So there is a recommendation to think of obesity-specific therapies. I'll not go into the depth because Shaila is going to talk on that. But liraglutide and semaglutide form important aspect of treatment of diabetes along with obesity. And of course, bariatric surgery also has its indication in diabetic patients, and sleeve gastrectomy is one of the recommendations in patients. So this patient, I shifted her to semaglutide and dapagliflozin, and I stopped her degludec for the time being, and I found that her glycemia was better controlled, her weight loss was better, her blood pressure reduction was better with the diuretic, and this patient actually did not need insulin. So this is how you think of obese diabetic patient with microvascular complications. The third scenario is elderly long-standing diabetes with a CABG and diabetic nephropathy, which started with this patient has already had a CABG, is having a diabetic nephropathy with eGFR of 42 and USAR going into the macroalbuminuria range. Patient is already taking triple drug with cilnidipine, with statin, with aspirin. And this patient is, what is the aim here then? So the aim here is, of course, to control the glycemia and high BMI, but major focus is on improving the survival and the mortality risk. So here I am thinking of CV and nephropathy protection factors, and and then my choice will go into different sectors. I know that HbA1c is known to affect the cardiovascular disease complication. 1% increase is known to increase the CVD risk by nearly 10 to 30%. And better HbA1c control is known to decrease all the risk factors, including the mortality risk, significantly in diabetic patients. So once this is known, this is the knowledge that I know, I need to convert this. And I need to improve the blood pressure. So you see that 5 millimeter decrease of blood pressure is known to improve all these parameters, including the brain vasculature and the cardiovascular benefit that it has to offer. And it's a significant benefit for a patient who has undergone a PTCA and is developing nephropathy. So what options again I have for this nephroprotection and cardioprotection? So here I think of GLP-1 and SGLT2 as the only options which are known to be cardioprotective. She's already taking aspirin, she's already taking statin. I continue with that. Overall benefits with these drugs have been in all these parameters a significant improvement in lipids, waist, weight, blood pressure and HbA1c. Also the pleiotropic benefits continue. I'm not going through all this, but we know that there is a multifactorial benefit with both these agents, the GLP-1RA as well as the SGLT2 inhibitors. They are known to work across the spectrum of cardiovascular disease and through various mechanisms. So you see the mechanisms vary differently, but majorly through salt loss, water loss, fluid loss, fat loss. So all these occurring in the one drug that we use. So what does the current guidelines say here? Guideline says that in these patients, either you use as SGLT2 inhibitor or a GLP-1RA, and you try to intensify their glycemic control. And here is the key, you need to refer rightly. Now referral, now for this patient, she is somewhere over here, G3B nephropathy. Here I am treating definitely. But the need for referral is also there for this patient with as a microalbuminuria is progressing. So this is a patient who needs a referral to the cardiologist, to the nephrologist, and see that this patient sees all the 3 doctors at one go. So I usually tell my patients that when you're meeting me, you're also seeing these 2 doctors every month. So this is how the management will go on to prevent worsening of the nephropathy. So this patient, she was again shifted to oral semaglutide. ACE inhibitor was added instead of cilnidipine. She also required dapagliflozin because of glycemic status as well as nephroprotective benefit. All these were added. Polypharmacy is a problem in this patient, but definitely the glycemic status and survival benefits are significant. Lifestyle intervention continues at the baseline. What has been added in the guidelines is something in relation to positive health behaviors. You can see that this was never mentioned in our previous guideline, that adequate sleep, the need for stepping, the need for sweating, the need for having a healthy lifestyle has been now clearly segregated and pointed out. So how much you need to sleep, how much you need to exercise is being mentioned. So to summarize, there is a need to move from glucocentric approach to a cardiovascular, renal, metabolic and adipocentric type of an approach. The right choice of the right drug is essential for cardiovascular benefit and MACE benefit. So the same drug may be wrong for another patient, right for one. And early insulinization and prevention of inertia is essential. Lifestyle intervention and is a basic necessity. So I think that's all in this, and thank you for the patient listening.
Thank you, madam, for elaborative talk. What we see in our clinical practice, diabetes patients, I think we need to customize our treatment as per the need of the patient, taking into consideration his health problem at that time, the comorbidities that what we see. And I think the important part in treatment of diabetes is lifestyle management, weight and exercise, counseling and health education is very important. Its importance cannot be overemphasized.
I think you will agree with me, apart from just controlling the blood sugar, she insisted upon the safety of cardiovascular problems and the renal problem. That is very unique and specific about this. I request if anyone has any question for the madam, please come forward.
Madam, experience of semaglutide in your practice? using tablet semaglutide?
Experience.
Yeah.
Okay,
Side
so
effect wise,
I have been using semaglutide both in clinical trials and in clinical practice, and it is in terms of glycemic potency, it is moderate potency. It's an oral tablet. It's a formulation available in 3, 7 and 14 milligram. The common problems that I have encountered is GI side effects. The patients do have a lot of GI upset. Some patients are able to tolerate up to 14, but many of them are able to tolerate only up to 3. So what I do is I start 3 milligram for 1 month, followed by 7 for the next month, followed by the 14 by the next third month. But what I've told the patients when I counsel them is that you need to take a antacid to start with, because you do get nausea initially, and you may not hurry to go into the next dose if you are able to not tolerate the higher dose. So you can go back to the previous dose. As of today, I have at least 100 to 150 patients on semaglutide, and they are doing well on that. If they are tolerating it, they are continuing. If they are not tolerating, they are withdrawing within a month's time. So the second and third visit, patient will tell you whether he wants to continue the drug or not. So he will tell you that, madam, ye stop karo ya ye chalu rakho. So that is what they do.
pancreatitis?
Yeah, I have seen one patient of pancreatitis in my trials with semaglutide, but we have not come across, and that too the pancreatitis is in the form of enzyme rise, not a clinical pancreatitis episode. That was one patient in all these patients in my own experience. But pancreatitis is, you should not use semaglutide in patients with pancreatitis, gallbladder disease, or with any GI surgeries, especially the bariatric surgery. Most of the bariatric surgeons do use it. I think there needs to be a caution when using it in such patients. So wherever GI upset is a problem, I use it commonly where appetite is a problem, where people are very hungry. So it cuts down appetite significantly, it helps in weight loss. I've seen 2 patients go on reversal of diabetes with semaglutide. So it's a good potent molecule. In fact, all the GLP-1 are, even with tirzepatide, my clinical trial experience says the same thing.
Rate malignancies?
Okay, so in family history of medullary thyroid carcinomas, or if you have a patient with goiter, or if you have a patient who has had a cancer of the thyroid, don't use it. So in goiter, if you are using, you will have to monitor calcitonin levels, so preferably avoid it. So MTC is a contraindication for use of GLP-1 RA. So all the liver disease, in fact NASH is improved with GLP-1 analog, but you don't know whether it's NASH or hepatitis. So you should be careful when you are using GLP-1 analogs in such patients.
Okay, then let us close this session with
Thank you
thanks
so
to
much.
Madam Deshmukh.
Thank you. I request